I'm going to share my slides. And Chair Foster, I'm hoping you won't require me to go through this twice just to be sure.
Not
Are you
planning
seeing
on.
are you seeing the slides?
Yes.
Okay. Thank you. So just a reminder of what we're doing today. The Health Information Exchange has to come up with a strategic plan, which they present to the board annually. The requirements for the plan are listed in 18 VSA section 9351A. And the requirement that the board approves or makes changes, request changes to the plan are outlined in 18 VSA section 9375. I went over these last meeting to outline what we were trying to do. The requirement to present information to us for the connectivity criteria from Vital and our obligation to review and approve are listed under 18 VSA section 9352 I2. Again, I'm not going to go into a lot of detail on these requirements, but the gist of it is that both the groups are required to present documentation to us annually about what they're up to with the strategic plan and the connectivity criteria, and the board has to review whether or not to approve those documents. The AHS submitted the update to the HIE plan and the connectivity criteria to the board on November 1st, as required. We've had a special comment period, public comment period open for this November 2nd to today. Last I checked, there has been no public comment made on this. The last meeting was November 18th. Both AHS and Vital presented the update and the connectivity criteria to the board. And then today, we're having the staff recommendations and the potential board votes and discussion about the plans. What we're looking for when we review the plan, the board has to consider whether the HIE plan requirements meet the requirements, of 18 VSA 9351. Is it consistent with the principles for healthcare reform that are outlined in 18 VSA section 9371? Is the HIE plan consistent with other relevant legislation? And finally, does the HIE plan incorporate national best standards and the expertise, as well as feedback from Vermonters, including key constituents? For the connectivity criteria review, we're supposed to review whether the connectivity criteria as they are outlined are in alignment with the planned goals outlined by the HIE, and whether the criteria will support implementation of the plan and achievement of the state's health reform goals. And we also want to have oversight over whether the connectivity criteria are sufficiently clear that they actually can be operationalized by Vital, by the state of Vermont, and clear to healthcare provider organizations. As I mentioned, we received no public comments to add on to this discussion. And here I just outlined some of the steps involved in the oversight of the HI, specifically 18 VSA section 9351A2 says that the board will either make required changes or approve or reject the plan within 45 days from when it was submitted, or also will be considered to be approved. The board will also consider the statewide health information technology plan. On a sec, having a little bit of an issue. We'll also check the plan to ensure that the necessary infrastructure is in place to enable the state to achieve the principles outlined in section 9371. And the board will review and approve the criteria required for the healthcare providers and healthcare facilities to be able to connect to the health information exchange. Further, within 90 days following this approval, the board shall issue an order explaining its decision. So those are the upcoming steps after today. I presented this last time. This is the list of plan requirements as outlined in 18 VSA section 9351. I wasn't planning on going into these items in depth, but I would comment that I believe that the plan meets these requirements, and specifically the strategic plan is presented, but the update addresses the efforts to promote use and awareness of the health exchange. It discusses the technology and other investments required to promote the use of the HIA, as well as how to fund the future work and current work. It highlights awareness of other ongoing HIT efforts and how the HIA can interoperate. HIT is health information technology. It extensively discusses data stewardship and governance. And given my background in cybersecurity and data privacy, I was particularly pleased by the depth of this discussion. It identifies national standards as required and how the HIE can best make use of them. And it does touch upon each of the 14 principles that are listed in 18 VSA section 9371 about the health reform goals for the state. For the connectivity criteria, the staff believes that the criteria do meet the requirements. The criteria align with the HIE strategic plan. These criteria will help the HIE implement their goals that they outlined in the plan, and the criteria are clear enough to be operationalized. So the staff recommend that we approve both documents. And I have presented here two separate motions just to start the discussion. But at this point, Chair Foster, I would turn this back over to you for discussion.
Thank you very much. I will open it. You know what? Actually, I'll go ahead and make the motion. We'll see if there's a second, and then we'll take board comments and questions after that. I think that'll work better. So I move that the GMCB approve the 2024 update to the HIE strategic plan as submitted, subject to the proposed conditions reviewed by the board today.
I can second.
And I will open up for questions and comments. There is a second, so we can, of course, change the motion if other board members would like to see something different, or we can adjust as we have questions and responses. So it looks like Member Walsh came unmuted. Member Walsh?
No, I've been unmuted, I think. Stephen, thank you for your work and your review. I don't have any questions at this time.
Are there any questions or comments on the motion for Dr. Andrews or other board members? Great. I'll ask the healthcare advocate if they have any comment on the motion or the presentation.
Just that we agree with staff that the board should approve it. Thank you.
Great. Thank you, Eric. And I'll open it to public comment via raise the hand. Seeing none, I'll call for a vote. All in favor of the motion, please say aye.
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 Aye. And the motion carries with 4 votes in support. Thank you very much, Stephen.
Here's the motion for the connectivity criteria approval.
And I will go ahead and make this motion as well. I move that the GMCB approve the 2024 connectivity criteria as submitted, subject to the proposed conditions reviewed by the board today.
Second.
Any board discussion? Healthcare advocate, any comment or remarks?
Comment, Chair Foster?
Yes, please. Oh, no comment. Okay, great. And public comment via raise the hand. All in favor, say aye.
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 Aye. And the motion carries with 4 votes in support.
Thank you, Chair Foster. That's all I had to present.
Thank you very much. Ms. Sawyer, are you here and prepared to present?
Yes, thank you, Chair Foster.
We worried we got to have a bit of load.
Your voice changed.
Hopefully it's back now.
You sound like yourself.
Beautiful. Okay. Thank you. We are here today for the Green Mountain Care Board staff presentation of One Care Vermont's 2025 budget. I want to just take a moment. You're going to hear a lot from me today, but I wanted to publicly acknowledge that I certainly did not do this alone. I have a great team of people that I work with here at the board. So thank you, all of you. So here is the agenda for today. We'll start off with an introduction and background, and then we'll dive into our review of One Care Vermont's budget. We'll start by reviewing the budget targets. We'll do a financial review. We'll walk through their population health programs. We'll look at a few different measures from their most recent benchmarking report submission, and then we'll walk through some options for budget modification and approval. Of course, there'll be time for board questions and discussion, as well as public comments. I'm going to hand it over to Mark Henksler, our staff attorney, to just walk us through some of the ACO oversight authority of the board.
Hey everybody, good afternoon. I'm quick today because we kind of covered a lot of this recently with Medicare ACO process, but the board regulates ACOs. It does so under 18 VSA 9382, and then we have Green Mountain Care Board Rule 5, which gets into more details for ACO regulation. Both cover certification of ACOs and budget review and establishment for ACOs. And we're here today on budget review for One Care. You can go to the next slide, Michelle. In particular, with budget review, the board has standards for ACOs with greater than 10,000 lives that are spelled out at 18 VSA 9382B1. When we were talking about Medicare-only ACOs this year, it just so happens to be the case that the Medicare-only ACOs all have attribution at less than 10,000 lives, which means that they're subject to review of criteria in statute as the board deems relevant. One Care, which happens to be the ACO that's also certified, has more than 10,000, so is subject to everything at 9382B1. I didn't make slides for every single criteria for in the statute because there are a lot of them and you've seen them again and again and again, but there's the site if anybody from the public wants to pull that up. So specifically under Rule 5.405 of the board rules, the board is considering a couple of things in regard to One Care budget for FY25. The first is any benchmarks or budget targets established by the board. Michelle will get to those in a minute. The second is the criteria listed in statute. Third is elements of the ACO's payer-specific programs and any applicable requirements of 18 VSA 9551. That's the all-payer model statute, or the Vermont APM between the agreement between the state of Vermont and CMS, and then any other issues at the discretion of the board. And finally, under rule, the ACO has the burden of justifying its budget to the board. So the ACO proposes a budget, the board reviews it, staff do recommendations, which is what we're doing today, and then the board either establishes the budget as proposed or makes modifications. I think that's it for me. So Michelle, take it over.
Thanks, Mark. All right, I did want to take the time to just look at this timeline because 2024, things have been just a little bit different than in previous years. You'll see in late May, the Green Mountain Care Board issued budget guidance for One Care, which is over a month earlier than traditionally is done. In addition, mid-June, the Green Mountain Care Board approved One Care's FY25 risk mitigation plan separate from the fall review of their full budget. Late August, One Care submitted their certification verification materials for 2025. GMCB staff continue to work through that and anticipate wrapping that up pretty quickly. One Care submitted their budget to the board on October 1st and appeared for their hearing on November 13th. We're here today, December 4th, for our staff presentation. And then 2 weeks from now, on December 18th, we have scheduled deliberations and a potential vote on OneCare's FY25 budget. As Susan mentioned, public comment is welcome on this budget through December 16th, so just a couple of days before that potential vote. And at this time, no public comment has been received. And then ongoing throughout 2025 and into 2026, we will continue to monitor OneCare's actual performance against its budgets, its approved budget, and any conditions. All right, so let's dive into the budget itself. We'll start with the budget targets. As Mark said, the GMCB has the authority to set benchmarks. The word benchmark is used a lot, so we've kind of colloquially started calling them budget targets. In 5.402, the board may establish benchmarks for any indicators to be used by ACOs in developing and preparing their proposed budgets. This year, we came up with 8 different budget targets that were included in OneCare's budget guidance. And then here's a quote from that guidance. It says, if the ACO's proposed budget varies from the budget targets below, the board will review the ACO's proposed budgets and its support for varying from these targets in its FY25 budget submission using the factors and criteria set out in statute and rule. For all budget targets that are met, the ACO should expect less analysis of this area of the budget from the GMCB and staff. And this also is pulled from the guidance, recognizing that FY25 is the final year of this ACO payment model. The focus on the ACO minimizing administrative expenses to support only programs shown to yield positive benefits in terms of access, quality, and affordability for Vermonters and positive benefits for Vermont community providers. The board was looking to finish this model out while freeing up resources to be deployed for future purposes. So here are the 8 budget targets. I am going to walk through them. So the first one was that the FY25 commercial benchmark trend rates must be consistent with the ACO attributed population and the GMCB approved rate filings. This is a pretty perennial target. It was met by MVP, and the UVM Health Network self-funded program hasn't been determined yet, but we have no reason to believe that it will not be in line with this target. Number 2, maintain risk corridors for all public payer programs at the minimum of the FY23 levels, or elect asymmetric risk corridor offered by Medicare. OneCare did not elect that asymmetric risk corridor, and they have a 3% risk corridor for both Medicare and Medicaid for FY25, so they do meet this target. Number 3, aside from waivers provided in the 2024 amendment of the all-payer model agreement, OneCare's FY25 budget should not support new programs. Administrative expenses should be associated with 1, programs demonstrated to yield positive benefits for Vermonters and Vermont providers, or 2, programs and resources necessary to support all payer model requirements, or 3, meeting payer contractual obligations and participation requirements. I think that based on prior years, the board could certainly find that OneCare has met this benchmark or budget target. But given that the recent announcement that OneCare is winding down, the board might re-examine the demonstrated value of programs funded for FY25. Number 4, the ratio of operating expenses to population health management / payment reform payments, this includes fixed prospective payments and budgeted bonus payments, must not exceed the FY24 revised budget amount. Yes, they did meet this. The ratio is acceptable. Number 5, the ratio of population health management funding to the number of attributed lives must be at a minimum of the FY24 revised budget amount. Specific line items may vary based upon any internal evaluation of the effectiveness of individual PHM programs. And yes, this target has been met. They matched their FY24 revised budget funding, so it's $165 per attributed life in population health management funding. Number 6, continue efforts around the 3 metrics that the ACO has selected to address in response to the March 2023 Medicare ACO Performance Benchmarking Report through the Quality Evaluation and Improvement Plan. The ACO should justify its choice of tactics to improve performance in these areas. So FY25 will be the second year that OneCare focuses on emergency department utilization, annual wellness visits for Medicare beneficiaries, and number of Medicare beneficiaries with a primary care visit. And we'll dive into their tactics in a later slide. Number 7, should the ACO choose to participate as an MSSP ACO in 2025 and leave the all-payer model, OneCare must submit a budget that reflects the fact that its value to the state is more limited and must provide any and all additional information as requested by the board. This is a kind of a moot point. OneCare did stay with the all-payer model, so they are finishing out the extension year. And number 8, the ACO must account for its administrative budget by providing a breakout of the budget by function. They did so in Appendix 6.10 of their budget submission. So recently, early November, OneCare announced plans that they would wind down operations at the end of 2025. All programs will continue to operate through that year as previously planned. OneCare has not requested any change to their budget that they had submitted prior to this announcement. OneCare leaving the landscape of Vermont healthcare reform leaves areas of uncertainty. I don't think I'm incorrect in saying 2026, there's just a lot of uncertainty in general, but OneCare leaving offers some specific areas where the board may want to consider the future. So the first is support for primary care and continuum of care providers. OneCare has provided population health management and CPR funds to support these types of providers in a financial way. The second is population health initiatives. These are initiatives that have incentivized care coordination, incentivized quality improvement, enabled waiver implementation, fixed payments. While we certainly did not get away from fee-for-service completely by any means, there were some fixed payments that were offered through the OneCare arrangement that will no longer be available once they sunset. Data analytics, OneCare had a really huge focus on data analytics and providing actionable information to their network, and with their loss, the network will lose that data analytics as well. And then last, the Blueprint and SASH funds, this isn't just because OneCare is closing. These funds flow from the federal government through OneCare to the programs, and we knew that with the end of the all-payer model, that we were going to have to get creative and try to figure out an alternative source for those funds. So here's OneCare's plans for 25 and beyond that they have shared with the boards thus far. They plan on maintaining their workforce through 2025 and will need partial staffing in 2026 for run-out tasks. For 25, they need to fulfill contractual obligations for both their payers and their providers. They express that they may reduce and eliminate expenses as necessary throughout the year, which would then reduce participation fees mid-year potentially. OneCare did not cite any specific contingency plans for staffing. Should they need it, they can lean on both the UVM Health Network and their broader ACO network for resources. They haven't shared any plans to migrate services with the UVM Health Network's Population Health Services organization, and they have no plans to modify their executive compensation program. And just to note there's an even more recent announcement from OneCare that came out yesterday that the current CEO has taken another position and will be leaving the ACO in the very near future, and that the current CFO will step into that interim position. All right, so let's dive into the financial review. So there are really two ways of looking at OneCare's budget. The first is the full accountability or total cost of care budget. You'll see the numbers there in the purple box on the left, $1.259 billion. And that includes all of the healthcare spending for OneCare attributed lives for those total cost of care services. And those are processed externally to OneCare. They're just pass-through funds. 2% of that number represent population health expenses, and 1% is administrative expenses. And then we can zoom into the entity level budget, which is in the orange. That includes revenues and expenses that are not contractually obligated to pass through directly to providers. So it includes participation fees from hospitals. It includes shared savings. It supports their operations budget. It supports some population health management programs, that sort of thing. And so we're looking at $21.9 million there. Here's a summary income statement. I certainly won't walk through line by line, but I'll just sort of orient you. We have several different columns. The first column there is for 2018 actuals. 2018 was the first year of the all-payer model. It was the first year that the board reviewed OneCare's budget. The next column is 2023 actuals. This is the most recent year for which we have actual financial data. 2024 projected. This is not, these numbers here won't align with what we saw in their budget submission, but rather on more recent reporting that the staff has collected from OneCare since their budget submission. And then we have 2025, what they are budgeting for. And then a couple of columns for variances between years. So we have a comparison between projected 24 and budget 25, as well as back in 2018 versus what they're budgeting for 2025. As far as the top half of this chart goes, or this table, this is all income, it's revenue. So I might draw your attention to the line for participation fees, and you can see how those have changed. These are dollars that come from the participating hospitals. Back in 2018, it was almost 4 million. And you can see 2024, it is projected to come down quite a bit, but back up in 2025. And then down at the bottom half, these are all of the expenses. And there is a line for a subtotal operating expenses. So their operating expenses back in 2018 were 13.7 million. 2023 actuals were slightly higher than that. And 2024, they are coming in with, I believe, their lowest operating expenses that they've experienced thus far at almost 6 million is what they're anticipating. And they have requested in their 2025 budget almost 8 million for their operating expenses. You can also see there's a line for net income for particular years where they did turn, I wouldn't call it a profit at all. It's for their reserves. And then you can also see some ratios down at the bottom of how much of their total budget was for their administrative purposes and their population health, including the blueprint and without the blueprint. So let's take a closer look at their reserves and net assets. The chart kind of speaks for itself. You can see that back in 2016, they had very minimal reserves, and it has grown over time. And we can explore why that is the case. So in 2019, they added $4.7 million to their assets so that they had about 5.7 million. The GMCB ordered the ACO to hold at least 3.9 million in reserves by the end of 29. So they did that. And they also came in under budget for both their population health and their operating expenses that year. No net assets were added in 2020. Certain aspects of their budget did come in under budget. However, they issued participation fee credits back to the hospitals. As we know, it was a very difficult year for our healthcare system, and so those hospitals were able to recoup some of that. 2021, they added an additional 1.3 million to their net assets. Again, population health and operating expenditures were both under budget. They did not issue any credits to hospitals that year. In 2022, they added $901,000 to their net assets. Their operating expenditures, again, were under budget, and they did not issue any participation fee credits. In 2023, an additional $595,000 were added to their assets. Again, their operating expenses were under budget, but they did credit back the hospitals $1.8 million. 2023 was the year that OneCare adopted a policy around how much participation fees that they could retain. And I'll dive into that in a little bit more detail in a following slide. And in 2024, they're projecting to add about $500,000 to their net assets. I wanted to flag that for 24, the ACO holds $7.6 million in risk for this program year. And it looks like their population health and operating expenses are going to, again, come in under budget. So what happens to reserves once OneCare sunsets at the end of 2025? They could certainly use it for staffing for 2026, since they won't have contracts with hospitals and be collecting participation fees from these hospitals. They won't have money coming in for operating expenses. So they potentially could use the reserves for that. As I just said, they hold $7.6 million at risk for FY24, and that settlement won't occur until 2026. So we really won't know if OneCare, if they will owe any money back to payers until that date. And then in 2025, they're holding $3.5 million in risk, and that settlement occurs in 2027. If after all of that, there are reserves remaining, OneCare's Board of Managers can direct those funds for distribution how they see fit. Here's that policy about hospital participation fees I just wanted to share. Essentially what it is that if the expenditures, or if revenues outpace expenses during a year, OneCare cannot make any more than 3% profit off of those participation fees. So that if they go above that 3%, the participation fees will go back to the hospitals the following year after their fiscal year audit. And so for FY24, they had budgeted $17.9 million in hospital participation fees, but they're projecting quite a bit lower than that at $14.7 million. And they are budgeting for 2025, $16.8 million in participation fees. Here's a look at their operating expenses, what they've budgeted versus their actuals. You can see in 2018, they came in with their actuals higher. They overspent by $1.25 million. But for each year thereafter, their operating expenses have come in lower than budgeted. For 2024, we're looking at a $1.74 million under budget. And the drivers of those savings for 2024 are namely salaries, paused development of some software, and their purchase services lines, some work with Vital and Arcadia. Let's take a look at their staffing. So for 2024 budget, they were planning on spending $7.2 million in expenses for staffing for 43.5 FTEs. What they're projecting now is that has come down to $6.56 million in expenses for 38.35 FTEs. And then if you jump over to the 25 budget, the expenses go back up to almost 2 million for the same number of FTEs for 2024, 38.35. So there is a 9.2% increase in staffing expenses between 24 projected and 25 budgeted for the same number of FTEs. The major driver behind that increase is the cost of fringe benefits, cost of living adjustments, and annualizations of mid-year 2024 hires. And then also there's information about what the median salary is. So the median salary for 2024 is $122,000 versus the median salary in 2025. There's an almost 4% increase, and that is the major drivers there really are the cost of fringe benefits and the cost of living adjustments. All right, so let's walk through the population health programs that OneCare offers its network. The PHM program, sorry, I think I'm getting an echo. So this program supports several different provider types, including primary care that are both hospital-owned, independent, and FQHC. It supports designated agencies, home health agencies, and area agencies on aging. So 2025 payments for primary care, they receive a base payment of $4 per member per month for meeting some pretty basic things like care coordination activities. And then there is the opportunity to earn a bonus payment of $5.25 up to that amount per member per month based on quality performance in a set of metrics. The ratio between the base and the bonus has been slowly ramped up, so the base has gone down and the bonus has gotten bigger to try to push providers to incentivize them to improve their quality performance. And so the budgeted totals for OneCare, they're budgeting $7.2 million for their base and $4.7 million for their bonus. Designated agencies and home health, the way it works for them is a little bit different. 75% of budgeted funds are paid as that base kind of PMPM, and then the additional 25% is available as bonus payment. DVA is also throwing in $500,000 specifically for designated agencies based on quality performance. And you can see the budgeted total amounts there to the right. Area agencies on aging, very similar. All funds are paid out as per member per month. So how do they determine how much to put in that bonus pot? They have been doing this program for a few years now, and they are anticipating that 52% of eligible providers will be successful in earning the bonus dollars for 2025. And those bonus payments are paid mid-2026 after year's end, and they have a chance to look at the results of everything. One area of interest from the board has been how hospitals use these funds. So the PHM program, as we just discussed, in part supports primary care. And the way that the payment mechanism works is that these payments are sent at the TIN level. So if a primary care office is owned by a hospital, the hospital receives the payment, the earned population health management funds. And so we required OneCare, the board required OneCare to include language in their contracts with hospitals for 2025 that required hospitals to explain what they would do with those funds that were earned by their primary care providers. We received copies of all of the letters from the hospitals, and some, I would say there was a broad spectrum of description. Some hospitals were very detailed in down to the 0.5 FTE of what is done with those dollars, whereas there were hospitals that shared they generally support primary care operations with those dollars. So this slide just lists off kind of some themes that we saw in those letters. Next program is the Longitudinal Care Program. This is designed to support in-home services provided to Vermonters with chronic disease, a recent hospitalization, and barriers to self-management who would not otherwise qualify for home health services. This program was piloted in the Burlington HSA back in 2019, and the results from that pilot showed a 26% reduction in inpatient utilization, 20% reduction in emergency department visits, and approximately $6,000 in savings per beneficiary per year. The program fell off track. It continued to be funding, but it seemed like there wasn't really data being collected when OneCare reported efforts to bring it back in 2024. So the FY25 budget is $399,000, which is the same funding amount since 2022. The Regional Clinical Representatives program. RCRs are primary care providers in the ACO network. They review data and analytical reports specific to the primary care practices for which they are responsible for improving performance in PHM targets. So an RCR is responsible for a set of geographically appropriate practices to help them improve their quality. 9 of these RCRs were hired in 2024. The goal is for 12 in 2025. That would allow for the entire state to be covered by an RCR. When asked if there's any measurable benefit for this program, OneCare responded, it is too early to accurately evaluate PHM measure outcome impact based on RCR support, and it is not feasible to separate out RCR impact from the impact of other efforts, such as the blueprint, focused on the same clinical quality measures. The FY25 budget for this program is $300,000, which is $50,000 increase from FY24. And the comprehensive payment reform. The CPR program offers a fixed per member per month payment and a reconciled PMPM at 105% of fee for service to independent primary care providers. There is plenty of anecdotal evidence that the CPR program has strengthened its participating practices. According to OneCare, these practices have higher quality performance than their network comparators. And then when asking OneCare what their plans were for this program after 2025, they said that financial information related to the program has been shared with the state, so the efforts to explore opportunities to sustain the support of primary care, independent primary care, can occur after 2025. The budget for this program in 25 is $2.3 million, which is a $3,000 increase over the previous year's budget, but almost $200,000 less than projected. And then I wanted to look at OneCare's support of primary care over the last couple of years. So 2023 actuals, you can see by type, so hospital-owned primary care versus independent primary care versus FQHC, and then the bucket of all of that. It's not fixed perspective payment or fee for service. It's namely the population health type funding that they've offered above and beyond, the services that the providers give their patients. And then you can see the average attribution for each one of these years, which is important because a lot of these dollars are tied to attribution. The more lives there are, the more funding there is. And then you can see the amount per life for each year. So the amount per life in 23 was $85 per life. In 24, it's projected to be $95. And in 25, it's projected to be $87. I think the main driver of it going down is and I didn't mention this earlier, the mental health screening initiative has been rolled into the PHM program this year. So the mental health screening initiative incentivized providers to screen their patients for depression and do follow-up work around that. Those are still being incentivized, but just through the PHM program rather than through a separate program. All right, let's dive into the Medicare ACO performance benchmarking report. Just earlier this week, OneCare submitted their latest version of this. So we will just look at a handful of metrics at this point. So these are the 3 metrics that I mentioned in those budget targets back at the beginning that OneCare is focused on. They are incentivizing their network to improve these metrics through their PHM program. They have some measures in there that closely align with these metrics from the report. Their PHM measures are emergency department follow-up for patients with multiple chronic conditions, and then annual Medicare annual wellness visits, which does directly align. OneCare also has their performance incentive pool that rewards hospital service areas that have lower emergency department utilization. So how are they doing? The Medicare benchmarking report, this is the first submission of this report that includes 2023 data. So I wanted to look at trends from 2019 through 2023, as well as 2022 to 2023 change. So these are percentages. They are basically the percent change during this time. So in ED utilization, you want to see a negative change. You want ED utilization per 1,000 to go down. So from 2019 to 2023, OneCare experienced a drop in 0.8%, whereas the 90th percentile, this is the 90th percentile of nationally of ACOs, the highest performing ACOs in this specific measure. They experienced a 1.7% decrease over the same time period. From 2022 to 2023, OneCare experienced a 5.5% increase, and the 90th percentile also experienced an increase, but a lesser one at 2.9%. The next metric, percent of members with an annual wellness visit, from 2019 through 2023, OneCare saw an increase of 0.58%, whereas the highest performing ACOs saw a 2.25% increase. And then from 2022 to 2023, OneCare experienced a 5.5% increase and actually outperformed the 90th percentile, which experienced a 3.2% increase. The percent of members with a primary care visit, 2019 through 2023, OneCare experienced a decrease of 0.45%. And the 90th percentile experienced a 0.8% increase. I will flag that the numbers for this particular metric among those highest performing ACOs is like well in the 90% of their members receiving a primary care visit. So improving upon that is pretty tough. So I'm not surprised that in 2022 to 2023, there wasn't any improvement amongst those highest performing ACOs, but OneCare did experience a 1.8% increase during that time. All right, and these are two kind of broader metrics that I wanted to review. The total cost of care. From 2019 through 2023, OneCare experienced a 3.5% increase in their total cost of care, whereas the highest performing ACOs experienced a 0.7% increase. And from 22 to 23, OneCare experienced 3.4% increase, and the highest performing experienced a 0.3% increase. And the last one we'll look at is ambulatory care sensitive admissions, prevention and quality overall composite, which I felt needed an explanation. These are admissions that have been identified as being able to be avoided or reduced with effective and timely use of outpatient care. This metric aggregates all specific ambulatory care sensitive admissions. So from 2019 through 2023, OneCare experienced a 6.8% decrease, which is a good thing. And the top performing ACOs experienced a 9.7% decrease, which is great. And then from 22 to 23, OneCare experienced a 4.1% decrease, and the top performing ACOs a 6.7% decrease. All right, so I would like to now walk the board through some budget modifications and approval options. We're going to start with potential conditions that are consistent with previous years. And I know you all know this, but no vote is needed today. These are just for review. So these aren't the technical language that would appear in a budget order, but rather just some kind of abbreviated language. So the first would be to notify the Green Mountain Care Board of any material changes to their budget and explain the variance. The next, OneCare would notify the Green Mountain Care Board of any use of its reserves or a line of credit or adjustment to participation fees. The third, provide Green Mountain Care Board a reconciliation of all FY25 PHM payments following the end of the fiscal year. And over the duration of the APM agreement, OneCare's administrative expenses must be less than the healthcare savings, including an estimate of cost avoidance and the value of improved health projected to be generated through the model. Next, implement benchmark trends, trend rates for payer contracts in alignment with the GMCB's decision on the Medicare ACO benchmark. There's a presentation on that next Wednesday and a vote noticed for the following Wednesday. The GMCB's Medicaid advisory rate case and for commercial payer contracts in alignment with the ACO attributed population and the GMCB approved rate filings. Next, engage in payer programs that qualify for all payer model scale to the greatest extent possible and align payer programs in key areas to the extent reasonable, explain non-scale qualifying programs and areas of misalignment, and to require continued reporting on payer programs. Next, fund population health management and payment reform programs as detailed in the FY25 submission as modified by this order potentially, and to notify GMCB of any changes, including funding shortfalls, changes in program scope, and an analysis for each program item as to whether and why the funding is appropriately scaled by attribution or some other factor. And finally, fund the support and services at home, the SASH program, and blueprint for health payments to primary care practices and community health teams consistent with the amount approved by the GMCB and the Medicare ACO benchmark process presented next week. Okay, here are a few that have potentially been removed for 25 for the board to consider. We could remove the requirement around the Medicare ACO performance benchmarking report. The intent behind that report was that was dual. It was both a mechanism for the board to evaluate OneCare's performance against its peers. And it was also supposed to be utilized by the ACO to as an area for improvement. They could look at and reach out to other ACOs and learn best practices to improve their own performance. The second for consideration is the removal of the revised budget as a required process in 2025. We could certainly modify it to say it could be ad hoc or to be determined, the necessity to be determined by the GMCB staff based on reporting that we receive from OneCare. The third would be the order or the condition that required OneCare to work with Medicare Advantage plans operating in Vermont to develop scale qualifying programs. OneCare will not be developing any programs beyond 2025. And then report FPP data and progress towards previously set goals. Again, there won't be much movement in the final year of this program. All right, and then I wanted to walk through some potential modifications for the board to consider. The first one would be to fund OneCare's budget as submitted with any or all reporting conditions as outlined in the previous slide. Or two, reduce OneCare's administrative budget, also I've referred to it as operating expenses, by $500,338, which represents the cost of the benchmarking report, the evaluation contract, lobbying services, and board of manager recruitment. Number three, reduce OneCare's administrative budget by $284,130 and reallocate $300,000 of population health funding, which represent the cost and the staffing expenses associated with the RCR program. And number four, reduce OneCare's administrative budget by $957,375, which is the difference between what OneCare is projecting to spend in salaries and benefits in 24 compared to what they are looking for in 25, including the expense of the CFO position since the CFO is stepping into the CEO role. 2, 3, and 4 could certainly, you could choose one, you could choose two, they can be, you could choose all three. Number 5. Any ordered reductions to the administrative budget shall result in a reduction of hospital participation fees. Or number 6, any ordered reductions to the administrative budget shall result in the reallocation of funds to independent primary care practices, FQHCs, another provider group. So the board would need to decide one or the other should they decide to adjust the administrative budget. And 7 would be that the board would require that OneCare adjust hospital participation fees at least once during 2025 to minimize hospital credits that are accumulated should their revenues be outpacing expenditures. The next slide is more for reference. If you wanted to see what that all would, if you were to stack options 2, 3, and 4, what that would look like, the different combinations. Not going to present that to you, though. It's there for your perusal. And with that, I will hand it back to you, Chair Foster.
Thank you. That was a really helpful discussion, Michelle. Any board member questions or comment or discussion?
I have a few. I could go first, if that's all right. So Michelle, regarding the 2026 run out staffing, do you have an understanding, is OneCare expected to come before the board again to present a 2026 budget? Or how do we understand how this is going to be funded, whether it's reserves and the staffing for that 2026 activities?
Sure. The first question, I think that is a legal question that is still under review by our legal staff, as far as a 2026 budget review by the Green Mountain Care Board. Regarding the second part of your question, I believe that they shared recently that they would do their best to obtain savings through their operational expenses in 2025 to fund 2026 activities. But barring that, they could potentially use reserves to fund those activities.
And my impression from your presentation was that whatever reserves are left over then goes to the board of managers to determine how they would be distributed back to hospitals or used in other fashion. But we don't, is there a process to, but as of now, we don't have a process to understand the impact of the 2026 staffing on those reserves.
Correct.
Okay.
And I might, yeah, and I'm not sure that OneCare would be able to speak to that at this time too, as I'm sure there's lots of uncertainty in 25 alone.
Yeah. Okay. On the benchmarking slides and slides 20, comparison group, is it a multi-payer comparison group? And do we have an idea of the distribution of the payers within the comparison group?
That is a great question. It is specifically Medicare ACOs. There are no other payers.
Okay, and is the OneCare component Medicare specific, or is it multi-payer on the
Yes.
OneCare side? Okay.
Nope. All Medicare specific.
And then on slide 26, we have attribution by for each of the years. Do we have attribution by payer type? Is that something you could provide me with some other point?
Yes, we can get that to you, Dave.
Okay. And then just one more question for you on this. On slide 21, you said that, so there's a DVA $500,000 payment. So that $500,000 from DVA is wrapped up into the next column, the DA payments.
I will double check on that, Dave, but I believe I did include those funds in that number.
Okay. I'm gonna hold other comments till later, but thanks.
Any other comments or questions from the board? I'll turn to the healthcare advocate for any comment or question they may have.
No, Foster, we'll submit our comments in writing before the period closes. Thank you.
Great. Ms. Sawyer, remind me when the vote is noticed for, if we've noticed it already.
The vote is noticed for 2 weeks from today, December 18th.
Right, thanks. Okay. And any public comment via raise the hand? Ms. Aronoff, how are you?
Good afternoon, Mr. Chair. I'm well. I hope you and all the board members and staff are well as well. I had a question about slide 21, and I'm not sure if your staff's going to be able to answer it, but this is the first that I've heard of DEVA giving designated agencies an additional amount of money for some sort of quality performance. So my questions are, is that $500,000 the total pool? Is that $500,000 per designated agency? And do we know, is that Medicaid funding that's being used? Tell me more. And if you don't know, where could I find out more? Thank you very much.
It's a good question. Thanks for flagging that. I don't know the answer myself. It is a good question we should have an answer to. Ms. Sawyer, if you have an answer, that's great. If not, we can ask the OneCare folks if they have any specifics, or we can connect with DEVA on that.
Yeah, that's a great question. The one part I can answer for certain is that it is $500,000 in total, not per DA, but I can certainly follow up with additional information.
Great.
Thank you. That would be helpful. Would I expect that at the next hearing, or should I contact you offline, or what would be best?
Ms. Aronoff, I know I have your email, so we can take a look at that. I think it's a good question, and we can either put you in contact with the DEVA folks, or we'll send you an email.
Okay, super. Thank you.
Sure. I see Mr. Boris has his hand up. I did want to congratulate Mr. Berman on your new job, and Mr. Boris on your promotion. Thanks for stepping up, and Abe, thanks for your work over the last year at OneCare.
Thank you.
Thanks so much. Appreciate that, Chair Foster.
Sure. Go ahead, Tom.
So I'm Tom Boris. I'm the CFO for OneCare Vermont, for the record. Firstly, thanks to the staff. I think this was a really nice presentation this year. Appreciate all the work that you put into it. Just have a couple thoughts that I want to share. The first is just an acknowledgement that the paradigm has changed for us. We built this budget last summer with the anticipation that we'd be in operations in 2026, and obviously that's not the case now. So I just want to name it, to put it out there that we get it, and I appreciate the staff recommendations that were put out today, but I do have a few thoughts about them. And really, I'm here to offer collaboration through this. I hope we have similar goals, which is to stay in operations throughout 2025, do our best for the state, the providers, the patients that they serve, and also be mindful of the cost borne in the system. So I understand the balance and the delicacy of those forces, but I'm here to help try and find a reasonable path forward for us all. Just a couple technical, and then I have a few higher level, but just regarding the use of reserves after we conclude and discussion starts with the OneCare board about what to do with those reserves. The only requirement I think is worth mentioning is that because we're a 501c3 organization, we can only distribute those to other 501c3 organizations, which naturally the hospital. So there are some rules and constraints, but ultimately it's a discussion the OneCare board will have at the appropriate time. Also, just to note regarding the PAR fees, I think it was discussed on slides 17 and 14. The 24 projection includes the proposed or budgeted deferral of unspent PHM money to be used in 25. That's why it looks a little bit lower relative to other years. That's been built into our projection of 2024. We've reduced or lowered the estimate of how much will be paid out next year as a way to kind of get you out in front of that, but that's why that looks like a dip there. All right, so I'd like to focus a little bit on the options that staff presented and just give a few thoughts. So starting with option one, which is no administrative cut. I mean, great, that'd be fine. Option number two, I don't have any concerns with this one either. This is the option to remove the benchmarking report and valuation contract, lobbying, board management's recruitment. We even offered that up in our narrative at your discretion. If you choose to do so, I have absolutely no problem with that. I think it's redirecting those funds to either primary care or back to hospitals, I think is a good use of those funds, keeps them in the state, which I think is a good thing. So I have no problems with option number 2. Option number 3 is a little bit concerning to me. This one relates to the RCR initiative, reducing the budget for both the RCR payments to the primary care providers across the state, as well as the staff time that goes into operating that program. Really, the RCRs are a critical way that we connect with and interface with our network. OneCare is very small. We have under 40 people, and yet we have this network that spans the entire state. So this was a strategy that we resurrected to ensure that we had a way to stay linked, connected, in discussions with providers across the state, and having a regional clinical representative that could really relate with and interface with many different practices and providers in that area was a part of the way that we could stay connected and in lockstep with our network, despite our very few number of FTEs at OneCare Vermont. I also think that the RCRs are a really critical part of our strategy to satisfy budget target number 6, which is to stay true on some of those areas of focus. And that's really what they help us work on in a peer-to-peer learning way. They also help us stay very connected with the blueprint, which I think is really important as we think about the next iteration of healthcare reform in Vermont. Having these connection points and building them, I think is an important thing and a value add for our state. So number 3, I do have some concerns with, and would like to see us sustain the RCR model through 2025. So number 4, which is to reduce the administrative expenses down to the fiscal 24 projection. Again, I acknowledge the paradigm has changed here. I understand this one. I feel it's important to note that even if this were adopted, because of ordinary cost of living increases, inflation, fringe rate, things that Michelle mentioned, we'd be starting roughly 500,000 in the hole. But really, I view this as a threshold. I think if we were to go any further past the cut in number 4, we're going to start to erode our ability to perform in 2025. And I think it's critically important that OneCare, through this transition, is able to do its best to support the provider network to get the best results and outcomes possible. I'd like personally to end the all-payer model era on a high note. And if we go beyond that level identified in number 4, I think we're going to start getting to a place where we risk losing our ability to have a positive influence on the provider network out there. And then really, when I read the slides this morning, my biggest concern is really if these options are combined. As I said, I think that option number 4 is really a threshold. And if that's combined with some of the others in light of the ordinary inflation expense that we expect to have throughout 2025, I think that we really start to eat into what we're able to accomplish as an organization. And that concerns me. Last comment, shifting just a little bit, but certainly related, is if this board were to choose to implement an admin budget cut, what to do with those funds. So certainly the options in slide 36 are reasonable. In general, our job is interesting at OneCare. We've been supporting primary care as much as we can since our inception. It's been a core part of our strategy, but we also have to do so in a manner that's mindful of where the funds come from, whether that's the state through any kind of contractual arrangements with Medicaid, for example, or in this case, hospitals. And I think it's appropriate in this circumstance that if there are budget cuts, that they accrue back to hospitals. It's really their money to begin with. And I think that's respectful of their budgets as well. So that would be my recommendation. I think option number 7 is one that I'm thinking about anyway. I don't know exactly how much, how many times we do a par fee adjustment, but depending on how 2025 pans out, it might be very appropriate to do that. I really have no intent of holding hospital money for any longer than we need to just fulfill our 25 business. And then, as was discussed a little bit earlier, potentially fund some of the 26 run out, which will extend certainly in a fairly substantial way into the first 5 months of next year, or 26 rather. And then there's some business that will continue on into August, September, October as well. So having some ability to generate savings that we can then use to fund that run out period, I think is a good idea. But again, 25 is going to be a dynamic year, so the magnitude is hard to predict at this point in time. Last thing I'll say is if there's anything else I can supply or OneCare can supply to help in your process, please let me know. Happy to supply anything we can.
Thank you very much. And we'll have obviously public comment if there's more ideas or thoughts you all have or input on these over the next 2 weeks. Please send them in. They're always helpful, so please do. Any other public comment? Okay. Seeing none, thank you very much, Ms. Sawyer, and everyone for the comments today. Just double checking our agenda. I think that's all we have. Is there any old or new business for the board? Okay, then I will move that we adjourn.
Second.
All in favor, say aye.
Aye.
All right.
Aye. Motion carries, and everyone have a nice afternoon. Thanks.